Welcome to another awareness session on something which we've never covered before, which is acute lymphoblastic leukemia. This is a two-part session. Today we talk about largely focused on recognizing it, being aware about it, knowing the signs, symptoms, and risks, and a little bit on treatment. And on Friday, we will talk a little bit more about the same condition. Today, we are very privileged to have with us Dr. Shrinath Kshirsagar and Dr. Siddhesh Kalantri. I'll introduce them in just a moment. Quick reminder to people who are new or who've not, Patients Engage is an online platform for patients dealing with chronic diseases, and it allows them and their caregivers to share personal experiences, information, and learn from each other. And we also believe that they should be better informed, and the more informed they are, the better choices they will make, because they need to make lots of daily choices as well for chronic disease management. And it also lets them know that they are not alone. There are others in a similar situation. In addition to patients sharing their experience, we also have experts who come in and share their knowledge as well, so that, again, the patients and caregivers are better informed. We've covered a wide range of topics as far as cancer is concerned, but we've not done as much on especially acute leukemias. We've done more on childhood pediatric leukemias. We've covered a little bit on overall complications of hematological cancers and bone marrow transplant, and we cover a lot of human interest topics around cancer management as well. Just a reminder again, on Friday, we will talk about navigating treatment options. That's at 7 p.m. Indian time on Friday, 11th of November. And that's with Dr. Soumya Mukherjee and Dr. Anshul Gupta. Today, we have Dr. Shrinath Kshirsagar, who is a consultant hematologist and bone marrow transplant physician at Global Hospitals in Mumbai. There's Dr. Siddhesh Kalantri with us, who's consultant hematology and Hemat-Oncologist and stem cell transplant physician in Nashik. I think it's a really good sign that we are having more and more options available for treatment across the country, and people don't need to spend time and effort to travel to the few metro places as well. And for those of you, I'm Aparna Mittal. I'm founder of Patients Engage. And also, general reminder that this session is being supported by Pfizer. It's an informational and awareness session and does not substitute medical advice. So please do consult your doctor for guidance on the information that is being provided. And the videos expressed in this are independent views of the speaker and not necessarily endorsed by Pfizer. Similar reminder from us as well. We are live on Zoom, Facebook, and YouTube. So you can post your questions and we'll try and pick up as much as possible. And once again, this is not replacing a medical consultation. So if you hear information that is possibly relevant, do discuss back with your doctor, or you can reach out to the two doctors here through setting up a consultation. And you can always contact us on our social media channels. We are on Facebook, Instagram, LinkedIn, Twitter, YouTube, as well as you can reach us on our website, www.patientsengage.com. So let me get started. Thank you, Dr. Shrinath and Dr. Siddhesh, for joining and taking time from your schedules to educate and inform patients and caregivers. Let's start with you, Dr. Shrinath. What is leukemia? Because people get very confused among the various cancers.
First of all, thank you, Aparna, for taking this initiative and making this platform available for general public. And also, I'd like to thank Pfizer for arranging this event. So coming to your question, leukemia is a type of a cancer, and especially it's a type of a blood cancer. So there are generally two types of blood cancer. One is a leukemia, other is a lymphoma. And leukemia, it's especially we label it leukemia when these cancer cells are seen in the blood. That means the blast cells, which are the immature cells, which generally stay in the bone marrow. When they start coming in your peripheral blood and they go beyond a 20% cutoff, then we call it as a leukemia. So generally, the leukemias are of two types. One is a chronic leukemia, another is a acute leukemia. Chronic means they are slow growing, while acute leukemias, which are rapidly growing. And there are further two classifications. This being depending on the cell type. One is a lymphoid leukemia, or other is a myeloid leukemia. So these are generally overview of a leukemia.
Right. Thank you. Dr. Siddhesh, if you can elaborate a little more as to what is acute lymphoblastic leukemia and how prevalent is it in India?
First of all, thank you, Ms. Aparna, and thank you, Faisal, for giving us this chance and making this platform open for everyone. So, coming to the prevalence of leukemia, now, whatever numbers I'm quoting are, I think, personally think this is underestimation of what has been quoted in literature. And the reason is that many people are not diagnosed because there are less number of oncologists or hematologists around. Many times these patients are just passed away as fever and they are not documented. But what's reported in Indian data is of 1 to 5 case per 1 lakh is what has been reported. And in certain areas, the numbers are a bit on higher side, but this is what has been reported.
Right. Dr. Shrinath, what are the symptoms and signs of, and we will refer to ALL, right, to make it simpler sometimes if we're talking about acute lymphoblastic leukemia.
So symptoms can vary, and symptoms can range from fever and weight loss. Then patient can also have bleeding gums or bleeding from their nose or bleeding through their motions or bleeding pervaginally. There can be multiple symptoms, and most commonly symptoms are fever, weight loss, and night sweats. Also, some of the patients can have a lymphadenopathy, means they can have a bulky swellings in their neck or in their armpits or in their groin, and these patients can be present with jaundice. And so this presentation is varied. No specific diagnostic presentation is generally present to diagnose ALL. So patient can go to multiple specialists with their symptoms. They can go to the general practitioners with fever. They can go to neurologist with headache. They can go to gastroenterologist with a bleeding from their motions, or gynecologist with bleeding vaginally. So symptoms are varied. We cannot just pinpoint a symptom for diagnosis of ALL.
Okay. So typically, what Dr. Siddhesh, do people kind of typically end up getting diagnosed late because of this challenge of symptoms being not so specific?
I completely agree with Dr. Srinath. Yes, there is delay in diagnosis happening. Many times simple interpretation of CBC is also not correct even at a good consultant levels. We have seen that is happening. So
Right.
people should be aware about red flags when they need to suspect that this might be something just not simple fever and they need a specialist attention for that. So agreed, the most common cause for low platelet with fever is dengue in the season. But if that is also present and that's beyond 10 days or 8 days that is happening, then we should think that something wrong is happening with us and we should take consults. People give steroids without knowing what exactly it is. And then when we get the samples, the peripheral blood is clean of blast. And then misinterpretation happens. So now what I feel is hematologists are available in most of the tier 2, tier 3 and tier 1 cities, and people should consult them if the fever is not going before taking any or addition of any steroids. So that delays the diagnosis, because what we can do on peripheral smear, we have to wait for some more time before we do bone marrow. So that is happening commonly.
So apart from symptoms, what are the red flags that people should be? Because you said people don't even, get the interpretation of the CBC report correct. So what are the red flags that you would recommend?
I think for acute leukemia, the word itself says that it's acute. So if somebody's general condition is going downhill in a very short period of time, if suppose my HB was 14 2 weeks before and now it has come down to 8, I think something is going wrong. Then if there are any bleeding manifestation which are happening, like if there is with fever, there is also melena, that's black colored stools which are happening, or if there is excessive bleeding per vaginally during periods, then these are the things wherein a person needs to be careful. Apart from that, if there are any black spots, petechials or hemorrhagic spots in oral cavity or in eyes or over skin, then again these patients should also consult a specialist, maybe a medical onco or hemato-onco, if anything is going wrong.
Okay, thank you. Dr. Shrinath, we've talked of various demographics, right? We've talked of women during periods. We've talked of so what is the typical age profile of ALL, and how different is it, or when is it seen different from, especially if you look at adult, when is it seen different from pediatric?
So generally, ALL as a bimodal peak means generally patients are seen in their early age group, means the patients are pediatric, generally seen in the pediatric age group, and generally these patients, ALL patients, can be seen in the adults also. So treatment is different for both the age groups, and generally, as per the available literature, males are more commonly affected than females. That is also seen, and because in children generally it's one of the most curable disease, and so but in adults is as notorious as it's not curable disease. So there is, out of 5, 4 adults die because of this disease. So this is very easily treatable and easily curable disease in children, but
Right.
in adults it's exactly opposite. It is one of the difficult diseases to treat, because most of the treatment whatever we are going to use in children, we cannot be using in adults, because of its complications and because of its side effects. So generally this is the demographic of the ALL, and treatment varies between the patient to patient. We have to tailor-made the treatment as per the patient's age, patient's gender, patient's financial condition, as well as multiple other things we'll have to take into the consideration before planning the treatment.
Right. Thank you. And Dr. Siddhesh, you talked of certain red flags in terms of your CBC, etc. But what is, once they get to an oncologist, how is it diagnosed? What are there tests that are done, or what is the process of getting it diagnosed?
So if the count is very high, for example, somebody's count is say more than 50,000 or 1 lakh, then the diagnosis can be made from peripheral blood itself. Like from CBC sample, we can do a flow cytometry, is high-end investigation wherein particular markers are added against the cells, and then we can identify which type of leukemia it is. Now, there are 2 things in leukemia diagnosis. One is investigation for the sets of diagnostic sake. Another is for prognostication. I would always tell my patients that don't compromise on baseline investigation, because you are never going to get those blast cells again, and you will never be able to identify the genetic makeup of those blast cells once the treatment has been started. So we always try to insist that do test for diagnosis, at the same time do test for prognosis as well. So for prognosis, if the count is more than 1 lakh, I can still go for genetic testings or like conventional karyotype from peripheral blood itself. But if count is somewhere around 20, 30,000, 40,000, I would push patient to do a marrow, because that gives me a better sample for doing genetic analysis. So certain doctors might suggest marrow, and I think here the consultant should take a call rather than patient taking call. Somebody might listen to me today and say, "Ki, my count is this much and a peripheral blood sample is enough." So that's not the case. Your doctor should decide what he thinks is right for you, and if he feels marrow is required, then that can be done. Apart from that, if ALL is diagnosed, then depending upon the condition of patient, platelet count, peripheral blood total count, and blast percentage, we might do a diagnostic intrathecal whether the leukemia has infiltrated spine, so or if brain involvement is there or not. So we do a fluid analysis of by doing a lumbar puncture from a spine. We take some fluid and we do testing for that also. So these are the investigations we do. Apart from that, we do investigations for looking for complications which has happened because of leukemia. For example, if patients creatinine is increased, if there is these blast cells, once they die, they release uric acid that might block kidneys. So if that is happening, so we check for that. If calcium is going down, we look for that. Then apart from that, if because of leukemia there is sepsis, then we look for LFTs or blood cultures. So these are some investigations which we do at baseline.
Right. Thank you. And Dr. Shrinath, what are the risk factors for ALL?
So to be specific, there is no risk factor for ALL, and there is no known risk factor for ALL, but it has been noticed that it can be seen in families. Means some of the relatives or some of the patient's parents may have this kind of acute leukemia in their family, and the children can get it. But to pinpoint particularly, there is no risk factors for ALL. So that's the thing.
Okay. And Dr. Shrinath again, so if you can talk now about the treatment options available for ALL.
Again, treatment is tailor-made as per the patient's age, patient's genetic factors, then patient's financial conditions, and many other things. And especially most important, the patient's caregiver's willingness to give the treatment. Because I always tell my patient, caregiver is the most important person in your treatment. You have to involve your caregiver as much as possible for your general discussion and your well-being. So first of all, treatment is chemotherapy. For baseline is a chemotherapy for a treatment for acute lymphoid leukemia, and there are multiple protocols which are available. So right from some people use German protocol, some people use American protocol. There are Indian protocols also available. So these are a group of chemotherapy drugs we combine in a certain levels and administer at a particular time period. Right. So initially, means for a first line therapy, it's always being a chemotherapy for ALL patients. And if patient is having a Philadelphia positive, means the Philadelphia chromosome is present in the patient, then we generally use a tyrosine kinase inhibitors that also are used in the treatment with the pH positive ALLs. And most importantly, if the patient has achieved some kind of a remission, means patient has achieved a disease-free period, and if the disease comes back, then generally bone marrow transplant is only curative option for them. So initially, for the first line therapy, we always use a chemotherapy. But in case the patient disease comes back at certain period of the time, then bone marrow transplant is been advised as a curative treatment for them.
Right. So I think so essentially, if I understand right, there is, for newly diagnosis, there'll be one line of treatment, and then if it is recurrent or relapse, there'll be a second line of treatment.
Yes. For newly diagnosed, generally only chemotherapy will consider for these patients. And if they do well on the chemotherapy, we generally leave them alone. And if at particular, after some period of the time, if they achieve good remission and if the disease comes back in the future, if their disease relapse, then generally we again give them chemotherapy, get them under control, and then plan to do bone marrow transplant for them for a better disease-free survival or for curing the disease.
Right. Dr. Siddhesh, would you want to add anything to that? Are there any other aspects that patient should be aware about in terms of decision making for treatment? I think you're on mute.
I think Dr. Shrinath has made a very relevant point about patients' relatives' involvement, which has to be there. Apart from the financial commitment, time is one more factor which is required because patients should be taken to hospitals on time. If there is fever, then we should be informed within 1 hour or half an hour of fever, because more delay you do, then in that case 8% mortality is there for every hour of delay which delayed information you give us. So this things are very important. And apart from that, I think food is also one important factor which needs to be taken care of. I am aware of literature which says that neutropenic diet is not required for treating leukemia patients or for treating cancer patients. But I personally feel that that's more relevant in Western world, where they have a very clean water and everything is clean. Your hygiene is compromised at every level. So I think there is no harm in giving cooked food, at least for intensive induction period, wherein the counts are expected to be very, very low. After
Right.
that, we can be a bit lenient in terms of allowing what should be eaten or not. But for first month, at least till the neutropenia is there and till the disease goes into remission, I am a bit strict on that aspect. But then again, scientifically, people might say that I'm wrong in my approach, but I feel we don't have enough hygiene in our environment or in our areas as of now to allow them to eat anything what they like.
Right.
We definitely
And the
cannot
risk of
allow them to
infection.
eat roadside food. That is for
Yeah,
sure.
we don't.
We cannot.
Right. And raw food as well, like
As
so.
we should
This
avoid
is
as much as possible.
Right.
raw food again. Here, fruits also people don't allow. What I have learned is we allow food with or fruits with thick skin, wherein worms cannot go inside. So we allow them watermelons, we allow them oranges, sweet lime, we allow papaya, but chiku I would not allow. Custard apple I would not allow, because you cannot identify many times the white worm in the custard apple. So
Right.
these things I would not allow, but like bananas, if it's intact, like it has been cut
Right. It
till
hasn't
end,
been broken
yeah. So
along the way.
then we allow that.
Right. Right. And you talked a little bit about being aware of watching out for symptoms like fever, etc. But are there side effects of these treatment options that patients and their families should be aware about, Dr. Shrinath?
Okay, so like my boss always used to say that chemotherapy is like a carpet bombing. So chemotherapy will kill your cancer cells as well as it will kill your good cells inside your body as well as healthy cells in your body. So there is a high chance because of the chemotherapy, your good cells like your infection fighting cells like WBC, especially neutrophils, will go low. And when the neutrophils go low, there is a high chance that the patient can get a sepsis or any infection. And generally that's because of the bacteria which is already present in the patient's body. So we should not ignore the symptoms like a fever, because like Dr. Siddhesh has already said, with 1 hour of a delay of a fever in the neutropenic patients, that will increase the mortality by 8%. So
Right.
we should not ignore symptoms like a fever, especially if patient is having a bleeding from anywhere. Bleeding can happen because of the low platelet counts, and that also can be a sequelae of a chemotherapy treatment. And so if any of the symptoms patient gets, they have to rush to the hospital immediately if they are on the chemotherapy, and maybe we'll have to start antibiotics immediately if they're getting fever. We may have to give them platelet support and to bring up their platelet counts and tackle the bleeding.
Right. Right. And you talked of the fact that actually I remember reading that one of the risk factors is if the patient has had previous chemo or radiation. Is that true for ALL?
Sorry, I didn't get your question.
One of the risk factors is previous history of radiation therapy or chemotherapy.
So yeah, so as you progress to your disease and as progress to your treatment, and as the patient has taken multiple cycles of the chemotherapy, their recovery of the WBC count goes down. So generally, sometimes as you advance in the treatment, your WBC will take lots of time to come up. That's because of the previous chemotherapies and because of the certain factors that can be seen. So yes,
Right.
because of the previous treatment, previous chemotherapy as well as the radiation, you are more prone to get this kind of infections.
Okay, thank you. And you've talked of the role of nutrition. Dr. Siddhesh, is there a role for exercise during and after treatment?
Yes, it is important. But again, when we do exercise, it's important that what are your hemoglobin levels? That's important, because initial time period, your HB is going to remain low. So don't try to overdo anything. Just be comfortable till the time your induction phase, like that is the most aggressive phase of your treatment, is over. After that, I would recommend to have at least like to do milder exercise initially, and then slowly upgrade as you tolerate it. Second is, with this backbone of steroid-based treatment, sugars are likely to go up. So
Right.
that is one thing which patients need to be aware of, and we ask them and we teach them, if possible, they can check blood glucose at home using glucometers. So that is also very important.
Right. So, if they don't have a prior history of
Can I make a comment on it?
Sure.
On this exercise part. So there is a published article which is available, and where they have evaluated approximately 30 patients of acute leukemia, and where they have involved exercise. They compared they are divided the patients into two groups.
Right.
One patient, they have given the exercise that's 4 times a week and twice a day, and this exercise contained both resistance exercise as well as the aerobic exercise, and they have compared with the non-exercising patients, and where they have found that a rate of pneumonia is much lower in the patients who undergo
Exercise
compared to control group, while the depressions and other factors and the patient's recovery was much better. That was seen in a exercise group compared to control. So based on this, generally we ask the patient to at least do some kind of exercise, at least to maintain at least a spirometry, a little bit
Right.
of walking during their treatment. So that
Right.
helps patient to get their thought process in a line. The patients feel better after doing the exercise, and if there is some trainer is available for doing their exercise, so they get to interact with those trainers. So it helps. That's what my personal experience is also there.
Right. Yeah, no, I think we do find, talking to survivors in general of most cancers, that there is always a benefit of exercise, but always listen to your body and
Yes.
be aware of that. I also wanted to talk about, there is this, I guess if it is just chemo, then the cost elements may not be high, but as you add other forms of therapy, does the cost go up, and how do you advise patients? How do you help them navigate that? And what are the, is that covered under various government and state schemes? Dr. Siddhesh? I think you are again on mute.
Yeah, in Maharashtra, what we have is there is a government scheme of Mahatma Jyotiba Phule Yojana, which is available. But again, when these policies were made, I think they lacked a futuristic approach while they made these policies. Just calculating cost of drug and making a package for 60 days for 50,000 rupees is not possible, viable, and even for doctors, for nurses, and the entire system. In any case, we do take patients in this Yojana thing, but over and above that, I think patients end up spending for their blood products, for SDPs.
Correct.
That happens. So that is one thing. Second is we have CanKids supporting. We have good options available for pediatric, but unfortunately for adults, we don't have enough foundations or people willing to spend.
Correct.
Again, crowdfunding platforms are always there, but I feel a bit misused at some hospital levels, and nowadays I think people have also lost some faith in them, and we are not getting enough goals which we plan for our patients. Apart from that, I think we teach relatives to administer antibiotics at home. That decreases cost of admission. We allow only those antibiotics at home which we have given in front of our eyes. Like if we are sure that patient is not having reaction to this drug, then we teach them in first 7 days. So in first 7 days, we have parallel teaching of mothers going on, and we are proud that mothers of our farmer kids are also giving antibiotics at home and then getting kids to hospital when they develop fever. So that reduces the time even from far off. When patient is coming from Chalisgaon to Nashik, he has already received first dose of antibiotic before he reaches our place. So we are doing that. And thankfully, as of now, I don't see any of my patient has died because of what we have done. If patient is stable, count are not very low. Like if they are in range of thousands and not in range of 100 or 200, I do allow them to take, and I know that what would be the duration of neutropenia which is expected. So if it's only 3-4 days, I do allow them to take antibiotics at relative's place and show me in morning and evening in my OPD, and this is how we decrease the cost. I don't know how Dr. Shrinath is managing. His setup is entirely different. I have my own clinic daycare, so but he is in corporate hospital, so I don't know how he is managing all this.
So cost is the most important factor in treating the patients with acute leukemia. Definitely, no denial to that. Managing the cost is a topmost decision. So what I do best, at least for ALL patient, we try to give as much as treatment as an outpatient basis. So that starts, so cost starts coming on the lower side. Then there are multiple agencies which are available, like Mahatma Jyotiba Phule Yojana and all those available. And but generally in my hospital where I practice, the corporate hospital, these are not very useful, because 50,000 is nothing for patients taking the treatment in corporate hospitals. So cost is a major factor, and as the treatment advances, then definitely it puts more and more burden on the patient. And antibiotic at home, this is also, we generally advocate for the patients who stay far away, as well as a patient who cannot afford to stay in the hospital for a longer antibiotic course. And liberal use of growth factors, that is also one of the most important decision we make for patients, admission, to reduce the admission numbers of the patients. So these are certain things we have to do. But cost, I don't have any answer to that, how to get the money, and how will it help the patient.
Right. Thank you.
I
know
one suggestion for this. Sorry. I would recommend that those who can afford should have good insurances. Like that is very important. Cost of premiums for younger age is peanuts if we calculate the cost per day you spend for per day, if you divide that cost of 365 days. So I think that is very important. Nothing will happen in 5 lakh, 10 lakh insurances in next 5 years. After that, you would require a good insurance somewhere around 25 or 20 lakhs. So I think that should be thing that should be encouraged.
Right. Yeah.
But there are lots of complications of insurance things also. That's what I have seen. So these most people take insurance, but this TPA generally are there to just to reject their insurance. I don't know why these people are sitting there, and why who are given the authority to reject the insurance despite of multiple letters to them. They are there to just to say, no, this treatment cannot be done in 2 lakh, 3 lakh rupees. You have to cut down on the price. So that's also sometimes we face the difficulties in that too.
I think we'll have to have a separate discussion on.
Especially, I make a point if we started the discussion. So generally, most of the treatments who are on oral-based treatment, these are not taken care by the insurance. So we should also find certain way to make our voice to reach government that this oral-based treatment has to made available by the insurance. Sorry for out of the syllabus discussion.
No, I think these are important discussions, and I think there needs to be kind of greater coverage of not just like the hospital stay, which is what typically most insurance will cover, critical care plus a few days afterwards. And we often hear patients talk of the testing before that doesn't get covered, and subsequent treatments that don't get covered after 60 days. And I think increasingly as patients engage, we are advocating that you also need to cover the rehab aspects, because without the rehab, it's not, you're not helping the patient get back to a productive, good quality of life. So these are important discussions, and I think it's good that we bring it up and we all talk about it. And I think there's a lot more to keep talking on this topic, but I think thank you so much. I'm aware that we have crossed the time. Any final words, Dr. Shrinath and Dr. Siddhesh, on what can be done for early diagnosis, or what should people be most aware of, both before they get diagnosed and after they get diagnosed?
First of all, one should not ignore their symptoms. If anyone is having a fever, and they should go visit their physician as early as possible. And also they should get their blood test done if the fever is not getting better despite of 5 days of treatment. And they should, if the blood tests are showing low hemoglobin, low platelets, or low WBC counts or high WBC counts, then they should consult hematologist or oncologist as early as possible. Then after that, further investigation needs to be done, especially bone marrow needs to be done, and we have to confirm the diagnosis of acute leukemia. As early we diagnose, better the outcomes are. Either if we delay the diagnosis, there is a high chance they may land up in some kind of a complications, like infections can happen, and they may have bleeding into the brain. So all those major complications can happen. So it's always better that we diagnose these patients as early as possible and initiate this chemotherapy for acute lymphoid leukemia patients.
Right. Thank you. Thank you, Dr. Shrinath. Dr. Siddhesh?
Dr. Srinath has already covered what I wanted to say, but I would just say that having blood cancer is not death sentence. People are cured with even with blood cancers, and we have very good, effective multiple lines of therapy at affordable cost available in our country nowadays. So I think there is no reason for you to be discouraged if this diagnosis unfortunately comes up to someone in your close network. So I think nowadays we aim to cure in the range of 70 to 85%, and we should have a fighting spirit, and you will get out of it.
Thank you. Thank you so much, Dr. Srinath and Dr. Siddhesh, and to Pfizer for supporting this initiative. And to our audience, thank you for listening. And and if you still have any questions, you can send it to us either on DM or through our website, and we will pick it up subsequently as well. Thank you so much, everyone.